Good morning. My name is O.B. Gray, and I'd like to welcome you to Shining the Light on Parkinson's Disease, an educational webinar on Parkinson's disease and the importance of clinical trials. This webinar is sponsored by Biogen and Proximity Health Solutions in collaboration with the Icahn School of Medicine at Mount Sinai Hospital in New York. Today, we have an expert panel of medical professionals and a patient advocate who will provide information on managing Parkinson's disease. They'll provide information on clinical trials and the importance of participation in clinical trials. Our expert panel includes Dr. Matthew Swan from Mount Sinai Hospital, Mr. Raymond James from the Boston University Medical Hospital, and Mr. Daniel O'Brien, who is a patient advocate. We have quite a bit of information to cover this morning, and we want to share that information with you. We hope that this information will be useful, and it includes an understanding of Parkinson's disease. It also includes information about how best to manage Parkinson's disease. And finally, it includes an understanding of clinical trials. You'll have the opportunity, throughout the presentation, you'll have the opportunity to send in questions through the chat on this platform. So I'd like to urge you to please send those questions in as they come to your mind, and we'll make sure that we try to find time to address any questions that you might have. After each presenter, we'll have the opportunity to answer some of the questions that presenter that are relevant to that presenter's subject matter. And then at the end of the presentations, we will be able to answer more. If we are not able to get to all of the questions that have been submitted by the viewers, I am relatively sure that the answers to some of those questions might be available to you in the resource material, which we will provide links to through a follow-up email. I just need to let you know, in full disclosure, that this webinar is being recorded. One final point before we get started is that we need your help in completing a survey at the end of this webinar. This questionnaire is a short questionnaire, and it's important because your feedback is valuable in helping us to improve the efforts to shine the light on Parkinson's so that they could benefit other Parkinson's patients. Everyone who is a U.S. resident who completes the survey will receive a $15 gift card. Okay. So now I'd like to, so let's get started. I'd like to turn it over to Dr. Matthew Swan and introduce Dr. Swan to you. Hello, Dr. Swan, how are you?
I'm good, how are you?
I'm doing well, thank you. So for the audience, Dr. Swan is he's the assistant professor of neurology at the Icahn School of Medicine at Mount Sinai in New York. Dr. Swan has been involved in clinical research in Parkinson's disease and other movement disorders for over 10 years, and he's the author of numerous publications. He currently oversees the clinical trial program in movement disorders at Mount Sinai Hospital. Dr. Swan is committed to education in clinical neurology. He directs a clinical neurology course at the Icahn School of Medicine at Mount Sinai, and he is a core faculty member of the neurology residency at Mount Sinai, Beth Israel. Again, welcome, Dr. Swan, and I'll turn it over to you.
Great, thank you so much. All right, good morning. So thank you for spending some time with us this morning. I'm going to be speaking with you for the next half an hour or so about what Parkinson's disease is and how you can go about managing it as well. So I think if we can get the first slide up here, we can go to the next slide, please. So one of the first things that I always try to establish with patients who are coming in to see me in the office is what they think Parkinson's is. What's their understanding of what this disease is? And there's a lot of different answers to that question. The big picture is that Parkinson's disease is a chronic neurologic disorder, chronic disorder of the brain that affects movement. It can affect coordination, and it can affect balance and walking. It's unfortunately a progressive disease. It progresses slowly, but it does progress over time, and we have no cure for it currently, although as we'll discuss, there are lots of different ways that we can manage the symptoms that people may experience. Some of those symptoms may include what we refer to as non-movement or non-motor symptoms, such as depression and memory problems, constipation or fatigue, as well as movement symptoms that include tremor, slowed movement, and stiffness in the muscles. And this is a disease that affects every individual who has it differently. It has different impacts on their lives and on their identity. And so really is an individual journey that is different for each person and each family who's affected by it. Can we have the next slide, please? So what are some of the symptoms that people with Parkinson's can experience? So at the heart of the disease and what many people think of are the movement symptoms, what we refer to as motor symptoms. A lot of people associate Parkinson's disease with tremor, and the tremor may affect the hands or arms, the legs, the face. But there are lots of other symptoms that people with Parkinson's can experience, and not all people with Parkinson's experience tremor. They can have muscle stiffness, or something we refer to as rigidity. Slowing of movements is very typical and really at the heart of the Parkinsonian syndrome. People with Parkinson's may experience more difficulty doing things like getting dressed, doing morning hygiene, showering, shaving, brushing teeth. These things can take longer and sometimes can require some assistance. People with Parkinson's can experience coordination and problems with balance. They may also experience a change in facial expression. They may have what people refer to as a masked face or a poker face, and they can experience pain and muscle spasm, as well as difficulty with chewing and swallowing. On the other side of the slide, we also list some of the non-movement or non-motor symptoms that can affect people with Parkinson's. So not everybody with Parkinson's experiences all of these symptoms, but these symptoms can, for many people, become even more of a problem and more of a nuisance than some of the movement symptoms. These include things like fatigue, dizziness or lightheadedness, disturbed sleep, difficulty falling asleep or staying asleep, mood disorders like depression, excess saliva and drooling, changes in speech, changes in blood pressure, which can cause lightheadedness or headache or mental fogginess. Some people can also experience gastrointestinal symptoms like slowed digestion of food, constipation or nausea, and bladder symptoms like increased frequency of urination or difficulty controlling the bladder, causing incontinence. And some people can also experience some skin problems like seborrheic dermatitis and even potentially an increased risk of certain skin cancers like melanoma. Can we have the next slide, please? We sometimes try to subdivide Parkinson's into different types. In particular, we like to identify those who have what we call idiopathic Parkinson disease, which is the majority of people with Parkinson's disease. This is to say that this Parkinson's disease doesn't have a clearly identifiable cause. In most cases, although we know some of the potential contributors to Parkinson's in general, on an individual basis, it's very difficult for us to determine what specifically caused the Parkinson's for a specific individual. In a small number of patients, 5 to 10 to 15%, depending on population, there may be genetic causes that we can identify, a single change in the genes in the body that lead to Parkinson's, but in the vast majority, that's not the case. In the office, we often also try to identify those who have a Parkinson's disease-like syndrome that is not actually Parkinson's disease itself. We refer to some of these as atypical Parkinsonian disorders, some of which are listed here, PSP or MSA, progressive supranuclear palsy or multiple system atrophy, as well as other causes of Parkinsonism like medication-induced Parkinsonism and changes in the brain due to vascular disease or repeated strokes that can sometimes cause a Parkinson-like mimic. Can I get the next slide? So how do you know if you have Parkinson's disease? In many cases, a primary care doctor, a geriatrician, or other internist or family medicine doctor will identify some of the early signs of Parkinson's and may refer a patient to a neurologist or even a Parkinson's specialist, a movement disorders neurologist. The diagnosis of Parkinson's disease primarily relies on a clinical assessment. So for the most part, we can make this diagnosis through a careful history. So we talk to our patients, oftentimes for a very long time, to figure out what their symptoms are, how those symptoms have progressed over time, and whether there have been any other changes in medications. We'll also do a careful physical examination, assessing vital signs, looking at the general physical appearance of a patient, and assessing their movement, their walking, their coordination. In some cases, we will refer people for other tests, although these tests are not absolutely required for making a diagnosis of Parkinson's. Sometimes we'll refer people for an MRI of the brain. That's primarily to exclude other causes of Parkinson's. In most cases, those with Parkinson's disease have a relatively normal MRI. And we may refer people for something called a DAT scan, which I'll talk about. I'll clarify what that is in a couple of slides. And sometimes we'll also confirm a diagnosis by using medication, particularly medication called levodopa or L-dopa, to determine if people's symptoms improve on that medication, and that can help support the diagnosis. Some of the things that we specifically look for on the examination are these motor symptoms or movement signs on exam that include the tremor, the slowing of movement. And in order to make a true diagnosis of Parkinson's disease, we have to be able to identify a specific type of slowed movement in patients. We also look at the muscle tone. We look for stiffness or rigidity in the muscles, and we'll look for changes in walking or difficulty with balance. Can I get the next slide? I'm just going to touch on some of the biology of Parkinson's here, and some of this can be a little bit confusing, but although we don't know in most cases what caused Parkinson's for a specific individual, based on years of study, we have a lot of information about what kinds of changes take place in the brain that lead to the symptoms of Parkinson's disease. Fundamentally, what we see are changes in certain brain cells in a structure called the substantia nigra. These brain cells deteriorate over time. One of the, or the main role of these brain cells is to produce a signaling chemical called dopamine. You may have heard of dopamine as a pleasure chemical in certain contexts. In this context, dopamine is a signaling chemical that helps facilitate movement. It helps the brain control movement. And dopamine is what we refer to as a neurotransmitter, which is to say a chemical that brain cells use to talk to each other to communicate certain kinds of information. When the dopamine levels get low because of the loss of these brain cells, people can experience those movement symptoms, the slowing of movement, the stiffness in muscles, and the tremor. And that loss of dopamine is really foundational, fundamental for those core features of Parkinson's. Earlier, at a prior slide, we mentioned this DAT scan. The DAT scan is a special brain imaging study that lets us look at how much dopamine loss there's been in the brain. So sometimes if we do a DAT scan and we see that loss of dopamine in the brain, it can help us confirm our suspicion about a diagnosis of Parkinson's disease. On the other half of this slide, there's also mention of the fact that other brain signaling chemicals, other neurotransmitters, such as norepinephrine, may be lost over time. One of the roles of norepinephrine is to help support blood pressure, which accounts for some of that low blood pressure that people with Parkinson's may experience. And there are also loss of other brain signaling chemicals or alterations in those signaling chemicals that can lead to some of those other non-movement symptoms that we spoke about earlier. Can I get the next slide? So some facts about Parkinson's disease. It's an extremely common disease. It affects about 1 million people in the United States alone, and probably 10 million or maybe more worldwide, maybe underdiagnosed in certain countries and certain communities. In the US, 13 out of every 100,000 people have Parkinson's disease, and every year 90,000 Americans are diagnosed with Parkinson's. Historically, Parkinson's has been considered to be more common among men, but worth noting that 400,000 United States women have Parkinson's, so almost half of the people with Parkinson's are women. We know that the risk of developing Parkinson's does increase with advancing age, and the average age of diagnosis is usually about the age of 60. However, it's important to note that Parkinson's can begin much younger. 5 to 10% of people with Parkinson's are diagnosed or develop symptoms below the age of 50. And the symptoms can even begin in the late 20s or 30s in a very small number of people. So this is a disease that affects people across the lifespan through adulthood. Can I get the next slide? So let's talk a little bit about how we can go about managing Parkinson's disease. And we'll talk about some of the therapies that are available, but also I really want to focus on what people with Parkinson's and their loved ones can do to address some of the symptoms, and advocate for certain treatments as well with their physicians and care team. Can I get the next slide? So as I mentioned before, Parkinson's is a very individual disease. Everybody experiences it slightly differently. They have their own sets of challenges, and they may have their own kind of constellation of symptoms. We have a lot of different treatments and medications that we can use to manage those movement symptoms as well as the non-movement symptoms. And a lot of the visits that we have with our patients are really about trying to identify what are the main things that an individual is suffering from that are affecting their quality of life or their function. And we really try to work in a collaborative fashion to figure out what it is that we can do to enhance quality of life and function. And again, that's really our goal. Right now, our treatments are predominantly symptomatic. We don't have any curative treatments, although we'll talk about the importance of clinical trials in a little bit for hopefully identifying some treatments that may slow progression. But right now, our goal is to identify those symptoms that are most impacting someone's function and quality of life so that we can address those. And as time goes on, the symptoms that are most bothersome may change in severity, or certain symptoms may pop up that are more bothersome than older symptoms people experienced. So it's an ongoing dialogue in order to identify what treatments and what our goals are to help our patients. Can I get the next slide? So we have a lot of different tools that we can use. This slide illustrates some of the different approaches that we use. Certainly we have a lot of medications that we can use to alleviate both the movement and non-movement symptoms in Parkinson's. We also will often refer our patients for various rehabilitative therapies, such as physical therapy, occupational therapy, and speech therapy. These treatments have a role to play for people with Parkinson's everywhere from the moment that they're diagnosed all the way through decades of disease, 20 or 30 years even into their disease. In a small subset of patients, there may be a role for certain surgical treatments, such as lesional surgery. Some people with Parkinson's have heard about this focused ultrasound therapy, which is an updated lesional surgery. We also more commonly refer people for deep brain stimulation, which you'll hear about in a little bit, and duopa, which is a form of medication that can be delivered through a intestinal medication port. And then we often will focus on lifestyle modification. And this is an ongoing conversation that we have with our patients, trying to promote movement, trying to promote exercise, healthy diet, and other healthy habits that can support brain health. Can I get the next slide? So in terms of some of the things that we try to promote in our patients to help them live the best life that they can with Parkinson's, there are a lot of things that individuals can do for themselves to improve how they feel and how they function. Some of these things include a healthy diet. In most of the studies that have looked at this, we have found the most evidence for this Mediterranean diet, which is considered the heart-healthy diet. It's also a brain-healthy diet. It involves a lot of plant-focused dietary habits, fruits and vegetables, legumes, nuts, and plant-based fats such as olive oil, and trying to minimize animal-based fats such as dairy and beef and chicken. We also know that even for people who don't have Parkinson's, as they age, staying physically active, staying socially engaged, maintaining a social network of friends and families, and maintaining cognitive activity, mental activity, can help maintain good brain health through later life. For our patients with Parkinson's, we often do encourage them to participate in some kind of a community of other affected individuals, whether that's a support group, or for some of my patients, they like to participate in certain exercise classes like the Rock Steady Boxing program or Dance for PD, which provide them a community of other individuals who are affected so that they can share their ideas, share their experiences. And I will say that in many cases, some of the conversations people have in these groups allow them to share what has worked for them, what has helped them, and sometimes that information trickles back to the doctors, and we learn a lot, actually. A lot of what we know for how to help people feel better, we learn from our patients and from other patients that they've talked to and what their experiences are. And we also encourage people to remain active in a community, participating in community events, participating in community centers or maybe a religious congregation, and participating in maintaining a social network outside of the home. Can I get the next slide? In terms of diet, as I mentioned, that Mediterranean diet is one that we focus on. But in general, we really like to promote a diet that's rich with fruits and vegetables for a lot of different reasons. One thing we also always promote is hydration. So making sure that you're drinking enough water is really important for managing some of those non-movement symptoms, such as the low blood pressure, the lightheadedness, constipation, and will help you maintain good energy. Fruits and vegetables are often high fiber foods that can help manage constipation. These include also legumes and whole grains. And some of the foods that we like to promote in that Mediterranean diet also contain a lot of what we refer to as antioxidants. These are chemicals that help reduce inflammation and reduce damage in the brain from inflammation. These are things like berries, green tea, dark chocolate, leafy greens, pecans, and beans. For some people with Parkinson's, swallowing can be difficult, and so we often have to modify the texture of diet or find safe swallowing practices to allow this rich and nutritious diet to be manageable. So that sometimes means taking smaller bites, chewing food a little more thoroughly, taking sips of water between bites, and also sometimes eating more seasoned foods, which can stimulate swallowing a little bit more effectively. Can I get the next slide? Another lifestyle habit that we promote, that we advocate strongly for in our patients is exercise. There's a lot of benefits from exercise for people with Parkinson's and for the rest of us, for people without Parkinson's, throughout the lifespan. We know that regular physical activity can help maximize function. We think that cardiovascular exercise can help with some of those motor symptoms, movement symptoms, and we also believe that cardiovascular exercise may have a protective benefit to the brain. It may slow progression of Parkinson's, and for people without Parkinson's, it may help reduce the risk of developing Parkinson's. We also know that movement exercise, whether that be cardiovascular, Tai Chi, yoga, dance, these things have benefits for the non-movement symptoms in Parkinson's as well, such as mood, sleep, cognitive functioning. And even something as simple as taking a walk outside can have a lot of benefits. So just walking for 30 minutes a day can improve gait and balance. The sunlight exposure that you get from being outside can help your body produce vitamin D, which is good for managing depression and sleep, and also very important for maintaining good bone health. And that physical activity can help reduce some of the fatigue and sleepiness that may affect people with Parkinson's. And also, it's a good opportunity for seeking out some of that social contact. Take a walk with a friend or family member can provide some of those social benefits as well. Can I get the next slide? So in terms of tips for taking charge of your medical care, as it says here, you want to be your strongest advocate. So some of the things that you can do to help ensure that you're getting all of your needs met by your care team include making sure that you have a team that you're comfortable with, finding a neurologist who you like, who you click with, who you share a similar perspective with, and also making sure that you have other care providers such as physical therapists that you like. Perhaps you need a cardiologist, a gastroenterologist, maybe a psychiatrist, and also making sure that you have adequate help for all the things that you need on a daily basis. Make sure to do research and inform yourself about Parkinson's. Unfortunately, there's a lot of misinformation out there on the internet, so broadly searching Google is not always the best plan, but there's a lot of really excellent resources out there. You'll hear about some of them later, but organizations like the Parkinson Foundation, the American Parkinson Disease Association, the Michael J. Fox Foundation, and the Mayo Clinic provide a lot of really valuable and reliable information for patients. So you can learn about your disease and learn about the symptoms you may experience, how to manage them, and advocate for those when you see your doctor. Keep track of what symptoms you have. Keep track of your physical activity, your diet, your medications. Definitely know who your doctors are and what their role is in your care. Sometimes it can get a little bit confusing to have more than one doctor. And it's important to know who to turn to if you're experiencing problems with certain symptoms. When you go to the doctor's office, sometimes the doctors are a little bit pressed for time, so come with a list of questions and priorities that you really want to try to address when you see the doctor, and make sure while they're asking you all of their questions, you can make sure to ask them your questions and raise any specific concerns that you might have. And it's always reasonable and probably a good idea to bring a friend or family member who can help you listen to what's being said, to remember what's being said. Sometimes it can be a little overwhelming to go to the doctor and get a lot of different advice about managing lots of different symptoms, and also to help you remember what it is that you want to ask. Definitely know what medications you're on and try to understand what they're for, and definitely let your doctors know if you're experiencing any problems with medications, if you're experiencing any side effects or any other issues accessing those medications. In fact, I'll just note one of the things that I often, in addition to monitoring for side effects of medications, one of the things that I often try to be mindful of as a neurologist is also the cost of medications. These medicines add up. And sometimes if a certain medication is no longer covered by an insurance plan, I like to work with my patients to find an alternative. And I think I encourage them not to be shy about raising those concerns with me also. Can I get the next slide? The last thing that I do want to mention in terms of making sure to maintain good brain health is managing sleep. Insomnia, difficulty falling asleep or staying asleep, is a very common challenge for people with Parkinson's and frankly for older adults as well. There are a host of other sleep disorders such as obstructive sleep apnea that can affect people's sleep quality. And we also often try to encourage good sleep habits, something that we refer to as sleep hygiene. Right? So we want to make sure that people sleep on a set schedule. If you go to bed at different times each night, it's a little bit hard to maintain a kind of normal circadian rhythm or biological rhythm linked to day and night. This is a hard one in our age of iPhones and tablets and TVs, but trying to reduce exposure to bright light before bed. That includes reducing exposure to screens. The blue light from screens can stimulate wakefulness and can reduce the quality of sleep. So trying to turn off screens 45 minutes or an hour before you go to bed can help you fall asleep more comfortably and stay asleep better. Trying to avoid things that are stimulating like nicotine before bed, and also certainly caffeine, and limiting fluid intake before bed so you don't have to get up to pee throughout the night. Sometimes people with Parkinson's can experience a lot of sleepiness in the daytime, so taking a nap, ideally planning a nap, building your day around it is reasonable. Many people get sleepy in the early afternoon anyway, and scheduling a nap is good. But I would say trying to limit that nap to 30 minutes or less is important. If you nap too long, your brain starts to go into a deep sleep, which can have negative consequences for your ability to sleep through the night. And when you get up in the morning, try to get some of that sunlight first thing. Open the shades, get outside. That sunlight will help your body link your internal clock to the day-night cycle in the world, and help keep you more wakeful throughout the day. Okay, and I think the next slide. I think that is my final slide. So I believe we maybe have some time for questions before we hand off to Ray.
Yes, Dr. Swan, we do have time for questions. And a couple of questions have come in, during the course of your presentation, Dr. Swan. And one of the questions that came in from a viewer is Parkinson's a hereditary disease?
That's a really good question. So there are a couple of ways of answering that. When we refer to something as being hereditary, what we most typically think of is whether or not there's a single gene, a single change in our genes and our chromosomes that can be passed from parents to children, that can be inherited and lead to disease. There are some genes, some single gene changes that can be inherited from parent to child that can cause Parkinson's. But these are in a small minority of people with Parkinson's, 5 to 10%. The majority of people with Parkinson's don't have a single identifiable genetic cause. It may be that there are different combinations of genetic risk factors that may increase the risk or reduce the risk of developing Parkinson's. But these are not inherited in this strict kind of hereditary way that many people think of.
Okay. Thank you. Another question that came in is, do Parkinson's symptoms worsen over time?
It's a really good question. Yes, unfortunately, Parkinson's symptoms do worsen over time. What we note is that Parkinson's disease is a slowly progressive disease. So many people with Parkinson's will live with their symptoms for 10 or 20 or even 30 years, depending on when they're diagnosed, how old they are when they're diagnosed. The symptoms do worsen over time, and sometimes people can experience new symptoms over time, which is part of why it's important to maintain a good relationship with a neurologist and other physicians to try to anticipate what those issues are, meet those symptoms when they come up, and try to address them. And over time, people sometimes do need more medication to try to address the symptoms as they progress. But our goal always, all along the line, is to make sure that we're maximizing function and quality of life to the greatest degree that we can through all of those different treatment approaches that we talked about.
Okay, thank you. And another question that came in is testing for Parkinson's disease covered by insurance, either Medicare, Medicaid, or private insurance?
Yes. So certainly much of the assessment for Parkinson's disease is done by a neurologist in the office based on the physical examination and the story that the patients tell. All of that is covered. The other testing, the MRI or the DAT scan, generally speaking, is covered by insurance. Sometimes the neurologists have to do a little bit of negotiating with the insurance to get it done, but yes, those tests are covered.
Okay. Okay. So, doctor, this is not a question that really came in on any one of the platforms, but I'm going to ask you this question because it's a question that came to my mind as I was listening to your presentation, and that is, what are some of the most common questions that you get from early stage Parkinson's patients when you see them?
Oh, that's a good question. You know, I think that the thing that the two questions that almost everybody asks me are, at some point in the early time after diagnosis, are what does the future hold for me, and what can I do to avoid progression? And we can talk about how symptoms progress over time, some of the challenges that may come up. And that's a conversation that we revisit throughout the course of the disease, trying to anticipate what future challenges might be. And then when people ask me what they can do to slow progression, a lot of the things that we discuss are some of the things that I mentioned over the last half an hour. Exercise, especially that cardiovascular exercise, trying to build a good habit of exercise. So the general recommendation for adults is 2.5 hours of exercise over the course of a week. It's about 20 to 25 minutes a day. For someone who's not been exercising, jumping into that degree of exercise can be challenging. So we work on strategies to work our way up, maybe 15 minutes 3 days a week, maybe 20 minutes 3 days a week, and work our way up from there. And we talk about some of these things like diet and sleep that we know can maintain brain health. Patients will also often ask me about how close are we to a cure for Parkinson's? And we can talk in those cases about what are the many different approaches people are taking to find treatments that may slow or stop progression of the disease, and many of the different approaches that are being explored along those lines, so that we maybe someday will have a little bit more tailored treatments to help people, not just symptomatically, but maybe to help slow progression to some degree. And I know that sort of leads into what Ray will be talking about with clinical trials as well. But I think, certainly for those who feel ready, participating in clinical trials, as we'll discuss, is an important way for sort of progressing advancing our understanding of Parkinson's and our ability to treat it better.
Thank you. Thanks again, Dr. Swan. That was very interesting and informative presentation for me, at least. Now I'd like to switch gears for a little bit and turn it over to a discussion about clinical trials. And to do that, I'd like to introduce Raymond James. Mr. James is a nurse specialist in the Parkinson's Disease and Movement Disorders Center for Boston University Medical Campus. Since 2009, Ray has been involved in the care of patients with Parkinson's disease, with Huntington's disease, and with psychiatric conditions and other movement disorders. Ray has worked in the movement disorder field of neurology since 2005, assisting and managing over 30 clinical trials. Ray is a member of the Parkinson Study Group, a consortium of international researchers who are focused on clinical trials for Parkinson's. And Ray's research interests include understanding racial disparities in Parkinson's care and research, as well as studies that focus on evaluating new therapies. So, Mr. James, I'd like to thank you very much for joining us in this webinar today, and I'm going to turn it over to you, my friend.
Fantastic, Obi. Thank you so much. Really appreciate you guys inviting me to be here, and thank everyone for taking time out of their day. to hear more about Parkinson's, what's happening in clinical research, and maybe how you'll be part of that. So let's go ahead to the next slide here if we can. Great. Yeah, understanding clinical trials, that is what we're going to talk about today. And go ahead to the next slide, please. Excellent. All right, so why are we talking about clinical trials? You know, we have a lot of therapies that are around. Dr. Swan very deftly mentioned a lot of different therapies and ways at treating Parkinson's and managing it, which is great. And how did we get there? You know, how do we know what works, what doesn't? You know, was it just a person on YouTube? Well, we have to get a lot further than that. So one of the best ways that we can evaluate whether something is truly effective is if we put it to the test with a clinical trial. And that is the gold standard in research for putting something to the test, really understanding how effective it is and how safe it is. And that is really going to be one of the ways in which new Parkinson medications and therapies are going to come about. And one really important step to this is making sure that it's regulated well. And so we have something called the US Food and Drug Administration, which many of you may have heard of before, the FDA. They review a lot of things besides just drugs, also devices and foods and all kinds of things that are out there that the consumer can buy. And so they play a really important role in making sure that what we have out there is safe and that it's effective for what its intended use is. And clinical trials are a big part of that. And more so, we want to go beyond just understanding whether something is statistically valuable. We want to see that it has importance to you clinically for your everyday quality of life. We might have a few improvement points on a Parkinson scale, but that doesn't mean anything unless it really changes how you live your life day to day. And that's what we want to get down to with clinical trials. And also really important to this aspect is that patients are part of this. Without your participation, these new therapies and things we hope for, we really want to push towards a cure, obviously. That's an ultimate goal, and every clinical trial gets us a step closer to that. So it's really critical that people participate. And I have to give you some stats on this too, but probably about 94% of trials finish late because they have trouble recruiting, and 30% of trials actually don't recruit anyone. They don't even get off the ground. So it's really important to think about this and start to reach out and look around you for clinical trials. All right, next slide, please. All right, so what does a clinical trial look like? Is it just a study and then it goes to the FDA? How does this all happen? Well, it has to be rigorous. It has to be scientific. You have to be able to validate and repeat the results that are going on. So clinical trials are broken up into 4 important phases. And even before it gets to phase 1, which you can see on this slide here, it actually goes through several years of preclinical testing where a drug or therapy gets tested in the laboratory, sometimes with animals, and made sure that it's safe and it does what its intended purpose is before it's tried out on people. Eventually, it can actually make its way to phase 1. So we're narrowing down from that funnel. You've got a big funnel of drug candidates or therapies, and they make it to phase 1. And we're going to look at a small group of people, often healthy individuals who are willing to test out a therapy. There's something called open label testing. That means that the drug is actually known to the participant. It's known to the person prescribing it. Everyone knows they're going to be taking this drug or using this therapy. We use something called blinding in future phases. And the importance of blinding is to make sure that people aren't having a biased opinion about the medication or therapy that they're testing out. But the primary purpose of phase 1 is to make sure that whatever it is we're testing is safe. And we're going to look at maybe 20, upwards of maybe 100 people. As long as it's safe, we can get to phase 2. And this is a part where we're going to introduce blinding that we just talked about. Make sure that the person, the investigator, the doctor that's giving you the medicine or therapy, that they don't know whether it's the active. They're going to be using something called a placebo in this case, and the placebo is a matching therapy, usually in the case of drugs, a sugar pill. And you'll be trying that out. And some people will be selected to try the active therapy. And we're going to look at a medium group of people, a couple hundred people that may be part of this. We need to look at some efficacy here. And as long as it's still safe, we see a little bit of efficacy, we can move on to the next phase, which is phase 3. And this is really the pivotal trial for a drug therapy candidate, because the results of this really determine whether the FDA will give a thumbs up or a thumbs down to approve it and let it move out to the market and let people try that new therapy. It's a much larger group of people, and it takes a huge body of folks to come together. Many different clinical sites, like, Boston University, Mount Sinai, many sites all around the US and sometimes around the world have to come together. And these studies have to be done so that everyone is trained, everyone knows how to assess what's going on in the study, what are the improvements we're looking for. If people get worse, we need to make sure to identify those things. And there's a lot of regulation that takes place. There's something called an IRB, or institutional review board, that reviews studies to make sure that they're done ethically and that they are having the intended effect, the positive benefit that we're hoping for. But people have to be aware of risks as well as they go through trials. As long as everything looks good in a phase 3 study, the FDA may approve that. They may ask them to go back and do more studies. But if they approve it, it'll go to phase 4. What does that mean? Well, it means that it gets to be marketed. It's out in the real world. It's tested on a much larger group of individuals. And that's where we may get more information about how safe and how effective a particular medication or therapy is. And one thing to realize, we see a lot of drugs out there that are very costly. The cost today to get a drug from phase 1 through phase 4, including that preclinical testing, is anywhere from $1.5 to possibly even $3 billion these days. That's based on data from 2009 to 2018. It's kind of staggering, actually. It's part of the reason that drugs are expensive. In oncology, cancer, you can double that number. And so those kinds of therapeutics are even more expensive. But it's a big hurdle for sure. Next slide, please. All right. So we need to make progress through clinical trials. I think we understand that. So if you're thinking, yeah, okay, I'm ready to jump in. Let me see if there's a clinical trial out there. Before you join a clinical trial, what you should understand is that there's an informed consent available for you to read, to take a look at. And you can come to someone like myself, a coordinator of a study, or a physician like Dr. Swan, and whether they're actually your physician or you're going to another medical center to find out about a study, they can provide you with a consent form. And this is going to detail a lot of information about the study, how long it is, what are the risks and potential benefits, and who are the people that you can contact if you have more questions. Next slide, please. All right, so let's say you've contacted that person, either me or Dr. Swan or whomever, and you go through the screening process. It's a bit of a pre-screen. So we ask you some questions to make sure that you're initially eligible for the study. Then we say, okay, let's have you come in for a screening visit, and we're going to do a lot more testing, things we can't just do remotely by phone or Zoom or what have you. And so you'll come in for a screening assessment. We'll make sure that the diagnosis is correct. I've had people come in and find out that their diagnosis isn't Parkinson's, it's something else. And so sometimes that's been a benefit to help them. So very interesting, part of the screening process. There's some other testing. We might do some scans like the DAD scan and other things just to make sure that it's safe for someone to participate in the study. There isn't anything that would complicate information that we get from the study. Like if a person has a different condition that maybe confuses what we're seeing in terms of symptoms. So what you would do in the study once you make it through screening is go to the baseline visit that follows. And at that point, you would be allowed to take a study medication or do a study therapy. And you would have to attend regular checkups, as you may say, or visits with the study team. Sometimes they're also your healthcare providers. And I think it's important to stop here for a moment and think, okay, clinical research, it's meant to benefit a lot of people with information, generalizable information, but it may not necessarily be for your care. It may help to inform parts of your care or may inform part of your care team about what your needs are. But the purpose of clinical research isn't clinical care. And I think sometimes that gets confused. We have to make sure that we have a separation, but also good communication between both groups. Okay, next slide. All right, so by the time you get through a clinical trial, there may be, if you're done taking the therapy or medication, you may have some follow-up. And they want to the researchers may want to find out if there's any long-term effects, whether benefits or not, from that particular therapy. And of course, it's really important to know that you can stop participating in a clinical trial at any time. You don't have to feel pressure. You shouldn't feel pressured by your study teams or wanting to make your doctor happy that you're participating in a study, so you keep at it even if you're not doing well. You really have to be open and honest with yourself and with your study team to make sure that they understand how you're doing. Because really, you are the paramount piece of clinical research, and your care is also, it comes before the research. So we want to make sure that people are well cared for as they're going through trials, and we communicate well with each person's care team. Next slide, please. All right, so there are some benefits of joining a clinical trial, some of which I've just talked about. Obviously, you're going to get access to new medications and therapies. That can be pretty exciting. I think right now is a pretty exciting time to be around in clinical research in Parkinson's. I've been in this field for over a decade and a half, and seen a lot of progress in that time. But of course, we want to see more progress. More than symptomatic therapies, we want to see things that slow progression and lead us closer to a cure. But this may also help to discover new therapies for your symptoms. You'll get close monitoring. As I said, we've got to have that good communication between care team and research team. If they happen to be different, they may be the same. And yeah, we want to make it generalizable. This information that we get should be something that we can apply to a lot of different people. So one of the stumbling blocks we have is trying to make sure that a diverse group of people are able to participate, that it's open. So we'll talk about how we can make that happen in clinical trials. And I think more is being done to push that through to make it possible for people to get over those hurdles. And yeah, for sure, I think feeling empowered to get closer to a cure, I think every study brings us closer and closer to that goal. Next slide, please. All right, so just some practical questions. If you're thinking, okay, well, if I'm going to be part of a trial, what should I consider? What should I even ask? I don't know. Well, think about how long a trial is going to last. Is it a month? Is it one visit? Or is it a couple years in some cases? And think about, can you get there? How are you going to get there? What's the distance? There may be ways that clinical trials can provide travel funds, maybe a hotel stay, something like that to help you get to the clinical center. You also want to know how many visits are going to be expected. Are you going to be on vacation while a visit is expected? There's usually ways to maneuver around that, but you have to think of these practical things. That's reality. So the other thing is you may have other priorities, right? You may be working, you might have childcare or caregiving responsibilities. Think about what you can do to manage that. If you're going to be committing to a trial, you got to make sure that you have someone to help you, back you up. So clinical research, it's not just the participant and the care team. It's a whole group of people behind each set that come together to make it happen. Make sure that you can adhere to the study protocol requirements. So, if there's a blood draw every time and you faint with a blood draw, that may not be the best clinical trial for you. But if that's something you're willing to go through in the name of science and to benefit your common folks with Parkinson's, then it's worth it for you, despite maybe that. And there's ways to get through that too. And compensation, I think that recognizing people's time to participate in research is important. It's something that you see more nowadays than you did in the past, where people had to say they were just lucky to be part of a clinical trial. Now we're lucky to have people participate in clinical trials. So it's kind of flipped around. And I think the emphasis is correct, that it's on the participant and their experience and what kind of information they're able to give us. So next slide, please. All right, so the purpose of this slide really is just to emphasize the fact that we really need that strong communication between the participant, person with Parkinson's. In some cases, we have people not with Parkinson's participating in trials, controls, so to speak, or people who might be at risk to develop Parkinson's. We can talk about that in a moment. But you really need strong communication between your care providers and your study team. We may come across, in the research world, we might come across some clinically actionable results. We had a person who had an MRI and found a problem there. And we were able to alert that person to get clinical care and follow up. So yes, clinical things can happen out of research, which is important. Also, as you're evaluating your participation in a trial, make sure that you talk with your friends, family, someone who isn't too nervous, not someone who's a big risk taker, but someone who's level-headed, who can help you ask the right questions. Lots of resources are out there and available to both you and your care team. And it's a great thing if you're part of a trial that you can share your experience and meet others as well. Next slide, please. I don't have time to talk about all the really cool clinical research that's happening now. Maybe we'll get to that in some of the discussion. But I wanted to highlight at least 3 really important trials that I think have groundbreaking possibilities to them. So PPMI stands for Parkinson Progression Markers Initiative. It's an observational study. It's not a therapeutic study. It's looking for a biomarker in Parkinson's. Now, biomarkers, very simply, it's evidence that there is a condition present. So, for example, diabetes, we see high blood sugar, for example. We don't have anything really like that in Parkinson's up until recently. And because of this study, we were able to develop what's called a seed amplification assay, or SAA test, for alpha-synuclein protein. It's a mouthful, but it's the misfolded protein we find in Parkinson's very commonly. There are some other Parkinsonisms that have that too, but this test was developed through this study using spinal fluid. So people had to have lumbar punctures as part of this study, and they committed 5 years of time, if not more. In some cases, we have people at 10 years participating. But a groundbreaking test, and it's out there now. The FDA cleared that particular test so that people could get that. It is something that is being used before diagnosis of Parkinson's is evident, before people have symptoms, for example, or clear symptoms. But one must bear in mind, as Dr. Swan said, that someone asked a question about, is it covered to get tested for Parkinson's? Yes, it's covered. But the key there was that a neurologist, a healthcare provider, someone trained in neurology, is doing the assessments, because it's more than just that biological marker that we need to really understand if someone has Parkinson's, and we'll go on to do, to get that. So that brings about a lot of questions, I'm sure, potentially for people. But SPARK study, I do want to mention this because we talked a little bit about exercise. This is the study of Parkinson's aerobic exercise, phase 3 study. It's supported by the National Institutes of Health. It's a 2-year study. And the goal of that is to see if it can slow progression. We know exercise is good for our cardiovascular health. We know that people report benefits with Parkinson's, but does it slow progression? Well, so far, we know in animal models it does. Often we tend to say we think it does in humans, but we don't have all the research to back that up, and that's why we're doing this massive trial, which is also an important one, comparing high and low intensity exercise. So that's a really neat one. Also, we have the LUMA study. This is a sister trial to the Denali Lighthouse study, which looked at individuals that had a LRRK2 gene mutation. And LRRK2, to kind of unpack that, it's a type, so we have a gene called LRRK2, and it codes for a protein, also called LRRK2, sometimes referred to as dardarin, which is, in Basque Spanish, it means trembling. So an interesting link to Parkinson's there. But it has a lot to do with protein communication and energy activation, but also is related to, if it's overexpressed, if there's too much activation of that enzyme, we may see oxidative damage and inflammation and neurodegeneration. And so the idea is, if we can target this, we might actually be able to slow the progression of Parkinson's. It's supported by Biogen. The expectation is people would take part for 2 years in that study. And initially, we're looking for people without a genetic mutation in LRRK2, because we actually find overactivation of this enzyme in folks that have sporadic PD, or idiopathic Parkinson's, a kind not generally linked with the LRRK2 gene mutation. So some very interesting trials going on. Obviously, we have others too. People have heard about the GLOVE trial and repurposing diabetes drugs for Parkinson's. So some really neat things there. But there may be some questions about that too. And let's go to the next slide. All right, so this is really nice, something provided by Biogen. It's the biogentriallink.com. You can actually go here, you can use your phone and scan it on the QR code, and you can find out more about participating in a clinical trial. And also you can even find out more about that LUMA study that I highlighted at the end of my last slide. It's really, we can't make much progress if people don't participate in research. So you guys are really the key to success and breakthroughs. And I want to thank everyone for taking some time to consider that. Thank you.
Thank you so much, Ray. We really appreciated the information that you provided. At least from my perspective, it was very informative, very helpful, I hope. And to build on the information that you provided around clinical trials, how they work, and what to expect from those clinical trials, what I'd like to do now is to introduce to the webinar attendees Mr. O'Brien, Mr. Daniel O'Brien. Dan is a patient advocate. And hey, Dan, how are you?
I'm fantastic, Obi. How are you?
I'm doing great, thank you. Doing great. So, so for the audience, Dan, as I mentioned, Dan is a patient advocate, and he's the president and founder of DOB Charities. It is a nonprofit organization that focuses on the needs of those in the community who are struggling with the daily expenses of living with Parkinson's disease. Dan was diagnosed with Parkinson's disease in 2012. And I have a quote here, but I'm going to let him say the quote in his own words. I would imagine at some point during his discussion with you. But our thought here is that Dan can provide some perspective on you for you in terms of his experiences in managing Parkinson's disease and his experiences in participating in clinical trials. And with that, I'm going to just shut up and turn it over to Dan and let him get started.
So thank you.
Okay, Dan. Thank you.
Thank you so much, Obi. I really appreciate you guys having me on here. Very important work that everybody's doing here on this panel. Doctors, the clinical trial people are amazing. As Obi said, I was diagnosed in 2012. Had no idea what Parkinson's disease was. Not a clue. Up to that point, I've been a rather successful musician, and you know, when Parkinson's hit, that kind of changed everything for me. So I basically tried everything I could possibly think of as far as medications, things that weren't even on the radar as far as that stuff goes. Eventually, I had the surgery, the DBS surgery, which was a game changer for me. I can play guitar again, nowhere near what I used to be able to do. But I'll give you a little demo on that right now, as a matter of fact. DBS is deep brain stimulation. Before I do this, I want to say one thing. DBS was brought about because people like you doing the clinical trials. Without that, I wouldn't be where I am right now. And I thank every one of you who's ever been involved in them. So here we go. Here's my hand. Whoop, let me get it in the right spot. I'm predominantly left-hand tremor, okay? And here's my little device right here. I'm going to turn it off. And within a few seconds, see how it says off? And I will turn it back on. Hopefully. I did that once and it didn't come on right away. Okay, there we go. That's a very, very powerful thing to show people. And it's all due, like I said before, to people like you going out there and participating in these clinical trials. When I was first diagnosed, I did the one for the DAT scan, which is now the de facto test for Parkinson's. And I would encourage every person out there who has this disease or who doesn't have it to go out there and get some clinical trial stuff in. Let's see, what else are we on here? We have that, we have that. Probably the best thing that I've ever done in my life is to get involved with physical therapy. I go 3 times a week still. I've been doing this now for almost 9 years. It's been a real game changer between that and the Parkinson's and the DBS. Everything is just better with exercise. I know that sounds kind of odd, but it's the truth. I don't have the slides or anything like that the other presenters did, because I'm what's known as a patient advocate. And what I do is I'm the South Florida, if you will, face of this horrible disease. We raise money and we give a lot of money away to people that don't have it. We had an event recently where we raised a good amount of money, and it's almost all passed out to people now that need it in our community. I really don't know what else to say at this particular point, so I'm going to turn it right back over to Obi. I know this was kind of short and all that, but if anybody has any questions that they'd like to ask, please feel free and get involved in a clinical trial.
Thank you, Dan.
You're welcome, my friend.
Really appreciate it. One of the things that I didn't mention is that Dan is modest. And I've had the opportunity to meet Dan before. Dan is a modest man, and he had mentioned, I believe, in his introduction that he was a professional musician, and Dan used to play with Eric Clapton back in the day. So I just wanted to throw that out to the group.
You know what, Obi? I didn't do my shameless plug here, if you don't mind.
Go ahead and do it.
I've written 2 books about Parkinson's. I never thought I would write a book in my life, let alone about Parkinson's. There's the first one. It's called Candid Reflections. Here's the second one about DBS. These are both available for free on our website, dobparkinsonscharity.com.
Got it. Okay, wonderful. So, so what we're going to do now is that we have several questions that have come in regarding clinical trials, and what I'd like to do is to bring Ray back on and Dan, and I could ask some of these questions so that either Ray or Dan can answer these questions. So the first question that came in regarding clinical trials is a question around the relationship between their current physician. And that question specifically is, can I keep my current physician? And if so, what is the ideal relationship with the clinical trial physicians and my physician?
Ray, what do you got?
I can absolutely speak to that. Sure thing. And Dan, I'm sure you could too, probably. But a lot of times patients of ours are participating in trials that we are running. So a lot of times we're one and the same. We're both providing care, and we're also trying to make sure that someone gets through a trial safely. So the nature of that relationship does have a duality to it, right? Like, so part of it is to contribute to that generalizable knowledge, to bring a new therapy out that might be applied to a lot of different people. That's the hope. That's the great thing we hope. But at the same rate, we want to be sure that we're looking after you, that we're looking at your clinical care, any new symptoms that you might be having. And as part of the clinical trial, you need to report that to the team, to the study team. And that study team will take that into account to make sure that it's safe for you to continue, or that they treat maybe some other new symptoms that you might be experiencing. So I think that's a really important aspect. And it's hard to make that division all the time. Sometimes in studies, we may have a different clinician do the assessments for a patient. So there really isn't maybe that bias or that feeling of pressure. And you can ask about that too. You can ask, well, will a different physician, be doing my assessments? And then maybe you won't feel that pressure to have to perform in some ways. We want to avoid the placebo effect for things, right? We see that in Parkinson's. We can see a positive improvement of 20 to maybe even 30% in people's symptoms just from a placebo effect. So we have to be really careful about that and making sure that people are as honest as possible about how they're feeling. But we're excited to be in a visit, right, with our clinicians, with our care team, who are also the study team. So we have to measure that. And that's why we do trials over a longer period of time, right? Because that kind of excitement, it doesn't last after the 3rd or 4th visit. You're going to get more real with someone about how you're really feeling once it starts to irk you. So, but don't let things get out of hand. That's kind of my comment, and make sure that you have strong communication between, if you do have a different team, both teams, care and also for research.
That's exactly what happened with me with the DAT scan. There was a lumbar puncture involved, and somebody else did it other than the guy that I thought was going to do it. And nobody had the foresight to inform me of that before. Now, having said that, everything worked out fine in the end. We kissed and made up, if you will, but it was a hairy moment or two there. I went to the hospital and I don't recognize anybody in there. I'm like, wait a minute.
Yeah, I bet.
So,
I'm going to bring Dr. Swan back in on this so he can weigh in on this question as well from his perspective, because I think to me, it is a very important question in terms of how, in situations when there isn't a match between the investigator site and a person's individual physician, how do you manage that relationship? So, Dr. Swan, from your perspective, what are the keys to a productive relationship with a clinical trial participant?
Yeah, that's a good question. I mean, I would just say, I would echo some of what's been said. That in our center, many of the participants in our trials are our own patients, and we do have to be very clear about recognizing the differing roles between being the doctor in the doctor visit and the clinical trialist in the clinical trial visit. So it's a little bit easier to maintain that separation when it's somebody coming in from outside. So I'll speak, I guess, first from the standpoint of the physician, the clinical trial physician. When I have patients who come to our center from outside, number one, I really want to make sure that I have good, clear records from their existing neurologists so I can know what their impressions are. And I try to maintain really clear communication and make sure that their treating doctor knows that they're participating in a trial, and provide whatever information I can about whatever information I'm authorized to provide about the nature of that trial, and keep the outside doctors updated on, if on their, again, to whatever extent I'm authorized to do so, on their progress through the trial. And I also try to make sure that the participant knows that they should contact us if they're experiencing what they think might be side effects from the study drug, but that also, and that we, and that we can, in the clinical trial realm, we can make adjustments sometimes to their treatment, their non clinical trial treatment if needed, but that they should also make sure that they're in touch with their existing neurologist and make sure to maintain that relationship. So there's a lot of give and take. It can be difficult. I see in the clinical trial domain, sometimes we see a patient participant every month for the first 4 or 6 months, much more frequently than they would be going to see their existing, their regular neurologist. So we may have to react to new symptoms sooner than they'll have an opportunity to discuss them with their neurologist. So I think clear channels of communication, and also, although it's challenging, making sure that our participants are aware of the differing roles that we have as the clinical trial team versus their doctor, who is whose sole job is caring for their symptoms. And our job is kind of this juggling act between, number one, absolutely maintaining patient safety and comfort and dignity throughout the trial, but also we have an obligation to the scientific mission of the study to make sure that we're getting good data and getting it on time, and sort of ensuring that the validity of this study is strong, so that if the medicine works, we have data that will allow us to get that FDA approval so it can be available for the broader population of patients with Parkinson's. And there's always some tension there, I think, no matter what, whether it's our own patient or whether somebody who's coming into our center to participate.
Mm-hmm. Understand. Okay. I have another question from someone in the audience, and that is, what new drugs or therapies are near approval with the FDA? Are there any new drugs or therapies that are near approval with the FDA?
I could speak to one that I'm eagerly awaiting. That I think it's pretty public that they're out there awaiting approval. We're actively there's a form of carbidopa levodopa, right? This is kind of our core therapy for people with Parkinson's, levodopa. And just for those who aren't familiar, levodopa is a chemical that gets into the brain and gets turned into dopamine. So it's a way of replacing that brain chemical, that neurotransmitter that's deficient in Parkinson's. Most of the forms of carbidopa levodopa that we have are oral forms. They're ingested. Even that duopa pump that I briefly alluded to is delivered through a medication port that goes into the gut. And the gut is, because the gut is affected in Parkinson's also, it's not the most reliable approach in many cases for delivering medication, especially when people need it on time so that they can maintain control of their symptoms. So there is a form of carbidopa levodopa that's developed to be delivered subcutaneously with a pump that can be provided during waking hours, or in some cases 24/7, to allow kind of constant and reliable delivery of that levodopa to the body and there to the brain, and reduce some of the ups and downs and inconsistency that people can experience from their oral medications. And there's a little bit of a race going on, I think, between two competing products to get FDA approval, but one has been before the FDA, as far as I understand, since the beginning of the year, and they're kind of in some negotiations reviewing the data. So I'm eagerly awaiting this for some of my patients who maybe aren't quite ready to go for deep brain stimulation psychologically, emotionally, or maybe they have some medical issue that's preventing them from getting deep brain stimulation, as Dan's had it, but still get a good response to medication, just have to take it frequently or experiencing a lot of ups and downs during the day. And this therapy, I think, will really be a life-changing treatment for them when it's available, hopefully before the end of the calendar year.
Would that be something that could be used with a person like myself that's had DBS?
I think so. I mean, the clinical trials for this excluded people who had DBS because it would be a little hard to control for that influence. But yes, I mean, I think that there are a lot of people who are exploring the potential for combinations of DBS and kind of continuous delivery levodopa as a kind of way of sort of mutually supporting those two therapies. So
I think I'm going to have to go on something eventually, because I can feel in the last month or so my Parkinson's is definitely intensified in the last couple months. But I haven't taken any medications in 2.5 years either.
Yeah, incredible.
Since the surgery. So I'll have to look into the one you're speaking of. Thank you.
Yeah, absolutely. Yeah, we're excited.
Sorry about that, Obi.
Oh no, that's quite all right, Dan. That's quite all right. Good question, And since you have him here, you may as well ask that question.
Yeah, really. I was like, okay.
Yeah. And someone in the audience probably had a similar question, so that's fine.
Did.
That's fine. Another question that came in is, will I be told if I'm receiving a placebo or the actual drug? That was mentioned during the course of the presentation. This question did come in, and I think I'll probably have a follow-up question after whoever answers this for the audience.
I'll let Ray answer that, I think.
Yeah. Sure, absolutely. So thanks. Yeah, so when we have folks come in for a clinical trial, they actually will not be told whether they're going to be on the placebo or the active drug. But what you will be told, is that there's a certain amount of chance that you'll be assigned to one of the groups. In some cases, there may be 2 different dose levels of a drug, plus there's a placebo. So you might have a 2 in 3 chance of actually being on the active study medication that's being tested. That's often what happens, and part of the talk was to emphasize the point of blinding and the placebo effect, to make sure that we aren't steering report of our symptoms in a positive way because we know we're on the study medication. So it's actually really important we don't tell you that, although a lot of phase 1 studies will tell you. And in some cases in a phase 3, like an extension trial, you might be on the active medication, but you might not know what dose level you're going to be on. So if you want to add anything else or follow up on that, please.
Yeah, I could just jump in with there too. I mean, I would say that for most of the studies I've been involved in, participants can eventually find out what they were taking. So they can't. The only times that we can unblind somebody is if we have to do so for the purposes of medical treatment. If they're experiencing some kind of significant side effect or other issue, or they have to go for some emergency surgery that, whatever it is, and we need to know what they're getting for delivering care, we can unblind, meaning disclose to the whole study team and the participant what they're getting. But otherwise, again, for that validity of the data, we have to stay blinded, and we as researchers also do. It's only when all of the data is collected and can't be edited in the database can we finally learn what people are receiving. because there's a lot of safeguards to make sure there's no bias that comes into that data at any point along the study. Even if a participant finishes the trial, if the trial is still ongoing, we can't find out until the trial is done and all of the data is locked, meaning that it can't be edited. And then we can find out. I will say that a common conversation I have when people come in to see me for a trial visit is this guessing game. They think, oh, I think I'm getting the drug, or I think I'm getting the placebo. And I have to be very careful not to tell them what I think, because again, I don't want to influence it. I don't know either. And I try really hard not to guess, because frankly, I've been wrong most of the time when I've tried to do that. So that blindedness is really key for the scientific validity of these studies.
I see.
And one thing, jump in and
Go
say,
ahead, Ray.
thanks, Obi, and thanks, Dr. Swan. I was going to say that often participants, right after they're done with the trial, will ask, okay, what was I on? Right?
Yeah, right.
It's usually, and you want to know, and we want to tell them, but we don't know, and we won't get that information sometimes for a year or two, or maybe even more later, because you have to get all the participants through, say, a 2-year study. And if you came in at the beginning, you got to wait those 2 years plus whatever it takes to get that last participant in, and after all the data is analyzed, right? Like you were talking about. So it can be a while before you finally get those results, but they are supposed to share that with you eventually.
I see. So a related question that I have is, what happens in a situation when a patient comes in for a clinical trial and they are on a medication right now that's addressing some symptoms, and they are doing so, and that medication is somewhat successful for them. Do the clinical trials preclude them from participating because they are on a medication right now? Would they have to give up their current medication in order to participate in a clinical trial? And if so, how do you help a patient sort through that decision matrix that they have facing them?
Yeah, I can start with that. I mean, that's a challenging situation. I mean, so the trials, every trial is a little bit different. And so it depends a little on what medication the patient's on and what the goal of the study is, what the design of the study is. In some cases, people can be on symptom therapy, symptom management, as long as they don't change that therapy right before they participate in the study, it's okay for them to continue it. In some of the studies, especially those studies that are looking at drugs that we hope will slow or stop progression of disease, in many cases they have to not be on any medication and either they have to have never been treated with medication or they have to come off of it, depending on the medication. And that's partially because in those studies, some of what we're looking at is when do people first start to need medication, and is taking the study drug delaying the need for medication, for symptomatic medication. So it all depends a little bit on the particular study. And there are sometimes medicines that people are taking, not even for Parkinson's disease, they're taking a heart medication or antidepressant medication that may interact with the study drug, and they either have to come off of it or they can't participate in the study. So I think that there's a conversation that we really have to have even before we screen a patient. We might pre-screen, meaning that we'll have a conversation with them before they come in for their first visit to look at their medications and see if there's anything that is going to keep them from participating in the study and anything that can safely be stopped. I think this is one of the challenges for those of us who are enrolling our own patients into trials where we're really torn about whether or not to stop a medication that we've maybe spent a lot of time kind of negotiating with the patient about starting or whatever. And it's a little bit of a, on the one hand, we really want to, encourage them to participate in a clinical trial. On the other hand, we've been managing these medications, and it can be, again, a lot of that tension. Ultimately, the number one thing is that we don't want somebody to do something unsafe, to come off a medication they absolutely need, or to come off a medication that may be, for example, a symptomatic medication for the Parkinson's that may be keeping them functioning. We don't want them to come off of that medication and be unable to function just to participate in a clinical trial. So the number one concern always is safety of our participants, and really making sure that we're not doing any harm by enrolling them in the study, changing their medication so they qualify for the study. But all of that is very study specific. So it really comes down to what the trial is, who the patient is, and then we have that conversation together about what's in their best interest.
Right, right.
Yeah, just one thing I'll say too, to jump in here, and I think it's why, you know, Dan is so important here as an advocate, and Dr. Swan, just everyone here really is educating folks about, once you're diagnosed, think about your options, because there are a lot of trials that require you to be off of a medication, and without hearing from someone like Dan or Dr. Swan or myself, you know, without getting access to education like this, you don't know that. And there are a lot of neurologists, general neurologists, who are great, but they may want to help those symptoms go away right away. And so they may prescribe Sinemet or a medication that's going to preclude you from participating in a trial. So it's so important to really think about what are your options. But like Dr. Swan said, your care and how you're doing is most important for sure.
Well, even with the DBS, you have to be off your medications, as you guys all know, when you're evaluated. And that was a nightmare, driving from Fort Lauderdale to Miami without any meds in me. And you get down there, and it was horrible. But, you know, the end result is amazing, and it was certainly worth it.
Yeah. Yeah, and that's a challenge, you know, for some of the studies that we do where we are assessing, looking for evidence of progression of the Parkinson's symptoms. And the most reliable way to do that is to look at people in their untreated state. So some of these studies will allow us to enroll people who are on medication, but in order to do the Parkinson's examination, we have to do that like 8 to 10 hours after their last dose of medication.
Oh, yeah.
They need to come in first thing in the morning off all of their medication. And it's not just the one time for the DBS assessment. In some cases, it could be every single visit. And that's a challenge. And we really work hard with our sponsors to make sure that we minimize the amount of time. You know, we have a workflow for the day to minimize the amount of time that our patients are off their medication, because it really is so challenging for some.
Yes, it can be.
Yeah, it really can.
And you know, thank you to all you guys, you doctors and researchers. You're the ones that gave me the life back, and I really appreciate it.
You're a good team where you are, for sure.
Oh yeah, no doubt.
Yeah.
No doubt about it. But I wouldn't even know about these guys if I didn't do my own research. You guys touched on that earlier too.
Yeah.
So,
I'm sorry. Go ahead.
Go ahead, Dan. Go ahead.
I have what I refer to as a practical doctorate in Parkinson's, because I've been living with it for 11 years, and I've read everything you can possibly think of. I mean, you were mentioning these sites earlier, Michael Fox and Mayo Clinic. I mean, these guys are like my Bible at this point. Every single day I get up and I do at least a half hour, 45 minutes worth of research.
Yeah.
And I speak to probably another 10 or 15 people in my area every day that call and have questions.
Yeah.
And I wouldn't have the answers without you guys. And I really appreciate all the work everybody on this panel does. And I thank you from the bottom of my heart.
Yeah, well, I mean, I want to sort of, I guess, throw it back too, and just say, you know, as I mentioned, you know, I think that our patients are our best teachers. Truly, so many of the little day-to-day pointers that I can share with patients, I've learned from other patients. You know, we have fellows who come after they finish their neurology training to come work with us for 2 years to become Parkinson's specialists. And, you know, every day they get to work with 6 to 12 teachers. Every single patient who comes through the door has something new to show them and teach them and explain to them and illuminate them about the experience of living with and managing Parkinson's. So I think the bottom line is I think there's a real dialogue that happens between doctors, patients, and other members of the Parkinson's community. I mean, I think seminars like this are good for that. I think a lot of the patient advocacy organizations like the Fox Foundation, like the Parkinson's Foundation, really bring in, you know, researchers, patients, and physicians, clinicians to have those conversations, because I think that it really takes the community of people affected with and concerned with this disease in order to get the treatments better, advance care, and and advance research.
Mhm.
I really feel that sense.
Takes a village, buddy. Takes a village.
Totally, absolutely agree. Yeah.
Great. Greg, well, we are about at the end of our hour. I'd like to thank Dr. Swan, Raymond James, and Daniel O'Brien for participating in this webinar. Importantly, I'd like to thank the viewers of the webinar, and I hope that you found this to be informative. I'd like to urge you and remind you to look for the link for research materials that we will send to the viewers of this webinar who have registered to their email addresses. And I'd also like to remind you to look for the link to the survey and to encourage you to please take a few minutes to complete the survey. It'll only take 2 or 3 minutes. Your feedback will be very valuable in helping us improve programs like this, which will in turn improve and provide a better life for Parkinson's patients. And please remember that every U.S. resident who completes a survey will get a $15 gift card. So this really wraps up our session. And again, I'd like to thank Biogen for being the sponsor. I'd like to thank the participants in our expert panel again. And importantly, I'd like to thank the audience for coming in and joining us today and helping to shine a light on Parkinson's. So I wish that everyone has a great day and a great balance of the week. Thanks again.
Thank you.
Yeah, thanks.